A very warm welcome to all the distinguished dignitaries from across the world and this beautiful country, Sri Lanka, to the 25th anniversary annual academic sessions of the Sri Lanka Association of Urological Surgeons. As we have reached a significant milestone, the Silver Jubilee in the history of the Sri Lanka Association of Urological Surgeons this year, we have lined up many informative lectures, including invited lectures and an interesting debate to start off this momentous day one. Before starting with today's proceedings, I would like to kindly request all the esteemed speakers to strictly adhere to the given time frame in order for us to efficiently conclude day one. Also, please note that the adjoining hall, the exhibition is open at the Science and Technology Hall for you all to visit whenever there's an intermission. With that note, ladies and gentlemen, it's with great honor that I commence today's academic proceedings. To chair this session, let me cordially invite the following revered individuals onto the stage now. The President of the Sri Lanka Association of Urological Surgeons, Dr. Manjula Wijewardena, the Honorary Secretary of the Sri Lanka Association of Urological Surgeons, Dr. Kalana Paranapalliya Guruge. Our first lecture for the day will be a virtual lecture on optimizing the management of high-risk prostate cancer conducted by the American Urological Association. And over to our moderators to introduce the speaker now. Thank you.
Good morning, ladies and gentlemen. So let's kick start with the first lecture, and that is by Professor David Penson. He's the current Secretary of American Urological Association, and he's the Professor and Chair at the Vanderbilt University Medical Center. And his specialty is in uro-oncology, so he's going to deal with the management in some issues with the high-risk prostate cancer. So it is a virtual lecture. Let's listen to him now.
Hello, my name is David Penson, and I'm the Secretary of the American Urological Association. On behalf of all the members of my organization, it is with great pleasure that I send my warm greetings to all of our friends and colleagues in Colombo, Sri Lanka. I want to thank the leadership of the Sri Lankan Association of Urologic Surgeons for the kind invitation to speak at your 25th Annual Congress. I'm only sorry that I am unable to be with you today in person to celebrate this major milestone in your history. On behalf of myself and the entire Board of Directors of the AUA, we wish you a heartfelt congratulations and hope that this meeting continues for years to come. The AUA really values your friendship and collaboration, and we look forward to continuing to work together long into the future. I hope to see all of you soon, and it is my pleasure to invite all of you to join me in Las Vegas, Nevada, in the United States for our 2025 AUA annual meeting next year on April 26th through the 29th. I assure you it will be a great meeting. Today, I'm going to speak to you about optimizing the management of high-risk localized prostate cancer. Before we start talking about how to treat localized prostate cancer, I want to make sure we're talking about the same thing. Here you can see the varying definitions of high-risk disease from various organizations. On the left, you see AUA ASCO, which defines localized high-risk disease as a PSA greater than 20 or grade group 4 or 5 on biopsy or clinical stage T3. EAU has a very similar definition. The only difference is that they include clinical stage T2C in localized high-risk disease. Finally, the U.S. National Comprehensive Cancer Center Network, or NCCN, defines high-risk disease as having none of the very high-risk features seen below and having at least one of the following, either being clinical stage T3A, having grade group 4 or 5 disease, or a PSA greater than 20, basically the same as AUA ASCO. Now, today I really want to talk about localized high-risk disease and not the worse cases of locally advanced high-risk disease or very high-risk disease listed below. I want to start by talking about imaging in high-risk prostate cancer. And this is a really hot area because of advances in imaging technologies that have occurred in the recent years. I'm specifically talking about PSMA PET scanning. Here you can see the results of a randomized clinical trial comparing PSMA PET to CT bone scan in localized high-risk disease. This study randomized 302 men to first-line conventional imaging or PSMA PET scan. And what I want to show you here in blue is conventional imaging and in red is PSMA imaging. And you can see for picking up any metastatic disease, the PSMA scan is superior to the conventional imaging in terms of area under the curve. And this is driven primarily by improved sensitivity without sacrificing specificity. When we look at pelvic lymph nodes, we again see that PSMA is superior in terms of area under the curve, again driven by sensitivity while maintaining specificity. And when you do sensitivity analyses, this association holds up. In fact, the imaging is so good, the management is affected by it, affected 28% of men in the PSA arm versus only 15% in the conventional arm. So clearly, this is an advance over CT bone scan. What about PSMA PET versus MRI for detecting lymph nodes in the pelvis preoperatively? Here you can see a meta-analysis of 13 articles, nearly 1,600 patients with intermediate and high-risk disease who were set to undergo surgery. And you can see that the PSMA group had a higher sensitivity than the MRI group. Specificity was equivalent, but in the end, the PSMA scan had a higher area under the curve at 0.92 versus 0.83 for MRI. Could we possibly use PSMA PET to identify lesions in the prostate? The answer is maybe. Here you can see a study of 74 patients with intermediate and high-risk prostate cancer who underwent PSMA PET, MRI, and then radical prostatectomy. And when you look at prostate cancer detection, you can see that PSMA PET alone identified 85% of lesions, MRI alone identified 83%, and PSMA PET plus MRI identified 87%. So in the end, PSMA PET and MRI is superior to either of the other two, but the differences are not so great that we necessarily have to do this. Now let's talk about treatment. You've done your imaging. It is localized to the prostate. Should the patient undergo surgery or radiation? It's a good question. Do we have any level 1 randomized clinical trial evidence to guide care? And the answer is not yet. SPCG-15 is a prospective randomized clinical trial comparing surgery to EBRT radiation and androgen deprivation therapy for locally advanced disease. This study will accrue 1,200 participants across 30 sites in Scandinavia. The primary endpoint is cause-specific survival. There are numerous secondary endpoints. The study opened 10 years ago, and in 2018 had accrued 400 participants. They've accrued since, and they estimate they will finish accrual in December of 2025. That means the earliest we will get an answer is 2030, and it'll probably be later than that. So we do not have level 1 evidence to guide us right now. What about level 2 evidence and lower? Yeah, there is some evidence there. This is a systematic review of treatments for high-risk and locally advanced prostate cancer. The authors identified 90 studies comparing various therapies. They focused on the 30 studies that compared surgery to radiotherapy. Only one of these was prospective. The rest were all retrospective. 11 reported radiotherapy as monotherapy without any ADT. 4 of the 30 studies included radiation doses of less than 70 gray, which is substandard. Still, 27 of these studies included data on overall disease-specific survival, and the majority of them reported a survival benefit for surgery, with a 10 to 28% benefit in overall survival and a 4 to 8% benefit in disease-specific survival at 10 years. However, the authors concluded that given the poor quality of these studies, no primary curative treatment modality has shown superiority over the others in terms of survival. So, we don't have level 1 evidence to guide us, so it really boils down to patient preferences and how we counsel them and our personal biases. So I want to talk first about surgery and then a little bit about radiation. What's the rationale for primary surgery in high-risk localized prostate cancer? Well, some observational studies have implied surgery may provide better long-term oncologic efficacy and local control. Surgery allows for pathologic evaluation of the specimen, which allows for better treatment individualization. Follow-up is simple. You just check a PSA. Patients may avoid hormonal therapy, and this is a great advantage. Hormonal therapy has a very deleterious effect on quality of life. So if we can avoid it, patients will benefit. And importantly, if surgery fails, adjuvant or salvage radiation is safe, effective, and is easily delivered if needed. Let's look at a couple of studies comparing surgery or radiation for high and very high risk prostate cancer. This is a single center study from MD Anderson from 2004 to 2013. 73 men were treated with EBRT and ADT. 231 were treated with surgery. The majority of these, 219, had high risk disease. Radiation doses were acceptable, and the median time on ADT was 22 months for the EBRT group. Median follow-up was 83 months. And here you can see the curves. In red is surgery, in blue is radiation. And you can see when you look at local failure, there may be a trend towards worse outcomes in the surgery group, but it's not statistically significant in the univariate analysis. Similarly, there is no difference in distant metastatic failure and no difference in overall survival. And in fact, when you do the multivariable analysis, there are no statistically significant differences, although there may be a trend favoring radiation in terms of local control. Maybe the problem is we don't have enough patients. So let's look at a bigger study looking at the same question. These are data from 14,726 men followed in the SEER registry, a population-based registry mandated by the US government. That means all the men in several states and cities who are diagnosed with cancer are included in this study. And basically, these authors use propensity score matching on a one-to-one basis for all the covariates of men treated with localized high-risk prostate cancer from 2010 to 2016. And here you can see the radiation is in red, the surgery is in blue, and cause-specific mortality is worse in the radiation group at 4.1% at 5 years compared to 2.3% in the surgical group. And because this is propensity scored, in theory, it controls for confounding, and it does show an advantage for surgery. When they took a larger group of patients, 24,000 plus men from SEER, and they didn't do propensity score matching, instead they did multivariable modeling, they showed that both for cause-specific mortality and all-cause mortality, when controlling for everything else, it favored surgery over radiation in both outcomes. But remember, this is an observational study. There may still be some unmeasured confounding. And so you have to think twice before you take this as level 1 evidence, because it's simply not. It is showing, though, however, that surgery may be better than radiation. The real reason to consider surgery first is because it allows patients to avoid hormones, and they may be cured with surgery. If we look at the 3 randomized clinical trials comparing adjuvant radiotherapy versus early radiotherapy in men with localized high-risk disease who underwent surgery, there is a message here. Here you can see the Radicals RT study from the UK, nearly 1,400 men in this group, followed for 5 years. And if you look in the group that was randomized to early salvage, what happened there was these men were observed. And if their PSA became detectable, that's when they received radiotherapy. In that arm, only 33% of the men needed radiotherapy, which means 2/3, 66%, were cured with a median follow-up of 5 years. And there's no difference in outcomes if they got the radiation late. If you look at the group from the study from Australia, New Zealand, RAVES, a similar study, similar results, 333 men, 6-year follow-up. Nearly half the men who were in the observation arm did not require radiotherapy. And again, no differences in outcomes. When we look at the French study, GetArg 17, same story, 6-year follow-up, 54% of the men who were in the early salvage arm ended up getting radiotherapy, which means 46% did not. So what that tells me is roughly 46 to 66% of men who have surgery with high-risk disease are cured with a single treatment, which I see as an advantage over radiotherapy. And importantly, if they need radiation, we can give it to them safely, giving them maximal local therapy. What's the argument for primary radiotherapy? And there is an argument there. You have to acknowledge upfront that ADT needs a second treatment, whether it's brachytherapy boost, which I'm not a fan of, but more likely androgen deprivation therapy. When you use XRT and ADT, it may have equal oncologic efficacy when compared to surgery. It avoids the perioperative risks of surgery, it avoids the quality of life effects of surgery, and it allows for treatment of the pelvic lymph nodes. In the United States, we've seen an uptick in the use of hypofractionated external beam radiotherapy over conventional radiotherapy. And in fact, our guidelines have been changed to recommend hypofractionated EBRT. This is an advantage because it's shorter. And here you can see a randomized clinical trial of 303 men randomized to conventional versus hypofractionated with a follow-up of over 10 years. You see there are really no differences in outcomes. So hypofractionated therapy is the way to go. But you have to remember these patients need androgen deprivation therapy, and they need it for a while. This is the BOLA study. You're all very familiar with this. They randomized nearly 1,000 men to either 6 months of GnRH agonist versus 3 years of agonist, both groups getting 70 gray of radiation. And you can see it favors the longer androgen deprivation therapy course. The 5-year prostate cancer specific mortality risk is 1.71. And so, in fact, ADT, you have to put in at least 3 years. Could you lower it? Potentially. This is a randomized clinical trial of men who received IMRT and were randomized to 18 versus 36 months of ADT. In orange is the 18-month group. In blue is the longer 36-month group. No difference in overall survival. No difference in disease-specific survival. A trend towards better outcomes in the longer group with biochemical failure, and possibly a trend towards better disease-free survival in the group with longer ADT. However, when you do the multivariable analysis, it all washes out, and there appears to be no difference. So it is completely safe to give your patients 18 to 24 months of ADT along with their radiation. So what's the take home here? What do you tell your patients? Well, the argument for surgery and pelvic lymph node dissection is that it may provide better cancer control and cure rates. It provides the most accurate staging and grading. PSA follow-up is simple. Patients may avoid hormonal therapy, which I see as a big selling point. Adjuvant or salvage radiotherapy is effective and safe if it's needed, and it's not needed in roughly half to 2/3 of men who have surgery. And if they do need radiotherapy, we're giving them maximal local therapy for what is likely a dangerous disease. Conversely, if patients want to have external beam radiotherapy and ADT, which is combined therapy, there's an argument for it. It may provide equal cancer control or cure rates to surgery. It avoids the perioperative risks of surgery. It avoids the long-term quality of life effects of surgery. It allows treatment of occult nodal disease. But you have to remember that your patients are going to be on ADT for 2 years, and they're not going to be able to have surgery. Surgery is very difficult and perilous, and the minority of patients are good candidates for salvage prostatectomy. So radiotherapy and ADT up front, in my opinion, is limited local therapy. It's appropriate for patients who want it, older, sicker patients, but frankly, I think that surgery is the better way to go up front. I want to thank you guys for your attention today. Again, I want to congratulate all of you on this momentous 25th annual meeting. And I want to invite you again to join us in Las Vegas, Nevada in April 26 to 29 next year for the AUA annual meeting. Thank you so much. It's been a real privilege to speak today.